In psychiatry, it's a problem, and in PTSD in particular, particularly with special populations like warfighters, police officers, and others, relying on questionnaires, brief screening measures, self-reports is highly problematic. Many who serve are reluctant to disclose symptoms that they have because of stigma, because of career ambition, because of privacy issues, and because they'd like to have careers in high security areas after they separate from the military. Yes, we have promising findings in a number of areas. In the brain imaging area, structural brain imaging using conventional techniques have been less promising. Functional brain imaging have produced very interesting new findings, both with the resting state functional brain imaging, in which PTSD patients show more activation of fear centers and less activation of emotion regulation centers when they're trying to relax. Task-based functional imaging shows differences where PTSD patients show a greater fear circuitry reaction to a stimulus like fearful faces with more amygdala activation. Blood markers are showing promise among some of the markers I presented today. Race and ethnicity are very important, as is gender. We don't think that the markers will be exactly the same in men and women. And among racial ethnic groups, our initial findings suggest some of the markers are prominent in Caucasians and not in Hispanic and African American groups, and some are more markedly altered in African Americans compared to Caucasians, for example. So I think, as is true in other diseases, race and ethnicity will have to be accounted for, and we have to be knowledgeable. Our initial phase of our work was to try to isolate markers that would separate PTSD cases from healthy controls in men. Next stage, do it in women. At the third stage, we've received a remarkably generous gift of over $20 million from the Stephen and Alexandra Cohn Foundation to answer the question you raised. In that study, we'll compare markers in PTSD, in depression without PTSD, in TBI, in PTSD and TBI with and without depression, and healthy control. So there we'll really begin to say what is unique to PTSD versus depression versus also traumatic brain injury. The field is rapidly advancing to a time where we can use technology, including the very sophisticated work in brain imaging and blood and other markers, to help with diagnosis, confirm and disconfirm diagnosis, to help screen who is in most urgent need of care, to use biomarkers to inform which treatment someone might benefit for, and importantly, which treatment might someone not benefit for. We would like to generate biomarker profiles that say, for this patient, psychotherapy is not very helpful, medication is somewhat helpful, but neurostimulation treatment will be remarkably helpful. And I'd also like them to understand that we're going to use biomarkers in the future to help understand what a person's prognosis will be.
This was last modified a year ago. So
who is likely to recover simply with the passage of time and support of family and friends or their military unit, and who is likely to become chronically ill and need active intervention.